Dr. Jaffe, can you explain the difference between the usual lab reference ranges that appear on lab results and the predictive goal values that you recommend?
Yes, we're talking about results of a test, but the interpretation, the meaning is vastly different. So when you have a result on a piece of paper and to the right, in general, there's a column called normal or usual range, it's to give indication about what a group or population of people showed in their values, and you're being compared to some statistical mathematical range whose personal individual predictive significance is often very marginal, to be polite. And to be more specific, when you compare an individual to a lab usual range, you're making people into statistics, and some of us in the field say you're making statistics out of people, which is not recommended. In our day of personalized medicine, in our day where we want to use information about how this result compares to the best possible outcome for the individual, we need to redefine the reference value. And so for us, predictive biomarkers are known to have best outcome goal values. And I'm going to go through 8 of the biomarker tests, the predictive biomarker tests, and offer you what is the best outcome goal value. And we then compare an individual to their best potential. And if they're at their best outcome value, we celebrate. And if they're not, we have a lifestyle program that in a matter of days, weeks, or a few months is usually able to move towards or maybe even return to that best outcome goal value. And we work with the individual on a biochemically individual basis to determine how much of each class of nutrients they need to meet their particular metabolic and biochemical needs. So the goal values for each of the tests are as follows. With regard to hemoglobin A1C, you want less than 5%. So you don't want extra sugar being stuck onto protein. It kind of gums up the works. With regard to high sensitivity C-reactive protein, or HSCRP, you want less than 0.5, indicating that your immune system is in balance and that there's not an excessive defense demand and a repair deficit in the body. In regard to homocysteine, you want less than 6 micromoles per deciliter. And this really says that the homocysteine is low and the methionine is high, so that methylation can go on smoothly but effectively. Then your lymphocyte response assay tells you whether you're tolerant or intolerant to foods, chemicals, and medicines and toxins, and you want to be tolerant. You want to expose yourself to those things to which you are tolerant. And if you're intolerant to any of them, you want to substitute, and we have a whole lifestyle program to restore tolerance while you're doing this substitution that includes replenishing essential nutrients so that the body can restore, renew, and rehabilitate itself. We also urge you to check how much mineral like magnesium you need using urine after rest, because at that point the urine has equilibrated with the cells that line the bladder, and you get one measurement of cellular status. And so if the urine pH is within 6.5 to 7.5, if the value on this high sensitivity paper, which gives you 3 colors, if it's sandy colored, light brown or yellow, that's acid. If it's green, that's good. If it's blue, that's alkaline and could be catabolic illness. These are almost always Goldilocks-like stories. You want to be just right. You don't want to have too little, not too much. And the next predictive biomarker test is vitamin D, which is really a neurohormone, and you want your vitamin D 25-hydroxy-D levels to be within 50 to 80 nanograms per ml. Some people say a little less, some people say a little more than that, but in general, the consensus is that you minimize your cancer risk, you maximize your neurohormonal communication when you have a 25-hydroxy-D level in the 50 to 80 nanogram or so range. Then you also have the omega-3 index, which you want to have more than 8% omega-3 fats so that you have a nice balance of omega-3 to omega-6. One of the big nutritional problems in America today is that we tend to take in 20, 40, 60 times more omega-6 than omega-3. And while we need both, we really need them in balance. And so we do not recommend edible oils that are omega-6 rich. We do recommend that people eat whole foods that contain healthy fats and then get a more than 8% omega-3 index, including supplementation of EPA and DHA as needed. The last is 8-oxoguanine. This is a measure of oxidative risk or damage in the nucleus, and we want that to be less than 5 nanograms per milligram of creatinine. It's a non-invasive test. It's less common than the other biomarker tests, but it does give us an insight into how much oxidative risk or damage is going on in the DNA and the RNA, and that is one that completes a component of the epigenetic path or the epigenetic territory that we think is important. So I recommend these 8 biomarkers. I recommend that you use the best outcome goal value and that you throw away the usual range unless you're working with statistics. And then if you really want to get into the laboratory technicalities, it turns out that the individual in front of you may not be represented by the 50 or so people from whom the statistics were derived about that laboratory range. So as a laboratory physician, as a clinician, as a systems biologist, and as someone who's interested in personal health and health promotion, I don't use lab ranges at all. I look at the individual and I look at the best outcome value for the test in front of me if I know it. And if there is no best outcome value, probably I don't need that test.